Good morning. Welcome to uh, another session of short course in clinical epidemiology. So today we will be looking at a new checklist which we have not done before, which is a target checklist. So this checklist is has been published to report a study which is looking at a target trial emulation study. So we have Dr. Anuka to present an article which is a target trial emulation study and see whether it has followed the steps advised in the target checklist. So I hand over to Dr. Anuka for the session.
Good morning. Today we'll be looking at target trial emulation. So in this, the checklist I am presenting today is a reporting checklist. So if you're doing a target trial, and you want to write it up, the reporting guidelines is one of the reporting guidelines is a target checklist. So today we'll be looking at what is this target trial, and we'll be looking at one study which has used this, and we'll be looking how it aligns with the target checklist, which is a reporting checklist. So we know the hierarchy of evidence. Randomized control trial give us a very good quality evidence in terms of a intervention study or a causal interference. Like if you want to know if something has caused, what is the outcome, we know that randomized control trial gives us a very good data. But there are some problems with RCT. It might be expensive, might be unethical, or may not be practical to do. So what is the solution for that? We know that we have lot of data in terms of observation study, a lot of real world data. Is there any way we can get a causal inference from that? We also know that there are a lot of problems with observation studies, biases and incorrect conclusion. So is there a way to reduce a bias and get data which is as good as a randomized control trial? So here comes the target trial emulation. So this designs the observation study like a hypothetical RCT. So we can that will aim to reduce the bias and whatever incorrect conclusions which can which can arise. So target trial is actually a hypothetical RCT that would have ideally answered the research question. Emulation is a observation quasi-experimental research design which emulates a randomized control trial structure within a large set of observational data. So this is nothing but a framework for causal interference from observational data. So just the terms I'll be using today. So target trial is a RCT that would answer the question of interest. Protocol is a detailed protocol which includes eligibility criteria, strategies, assignments, outcome, follow-up, what is the causal experiment, that is intention to treat or not, and statistical analysis. So this is similar to what we look in a RCT. And emulation is a process where we do this to get the data. So we know that, we looked at, we've learned that target trial emulation is a framework which you help to design. But what are the challenges that can arise? Now, when we look at a randomized controlled trial, there are three things which happen. One is you would have all the patients go through a process of eligibility. So we look at people who are eligible and then recruit them for the trial. Second, they are assigned the intervention. This is a randomized intervention which is assigned. So the time when randomization happens and they get the intervention is called time zero. So in a RCT, people who are eligible are randomized and they get an intervention, or they are in the study. That all happens at time zero and all of them are aligned. So usually, because they are all aligned, this is how we get a real evidence data. In an observation study, this may not be aligned. So that leads to some of the biases. So if they are all aligned, if they are all not aligned, it can lead to some biases, and we'll look at that. So we look at confounding bias, we look at what is immortal time bias and selection bias. So in a randomized trial, the time zero starts at randomization. And that is where the treatment assignment follows and you start to follow a patient. Now, if they are not aligned, some of the biases can happen and we look at that. So what is confounding? Confounding is a variable which would affect the cause and the effect independently. For example, if you look at, does healthy eating greens has benefit in cardiovascular disease? But we also know that exercise has benefit in cardiovascular disease, and people usually who take healthy choices in diet are people who would exercise. So exercise will independently affect the diet choice as well as the outcome. So confounder is a variable which will affect the cause and the effect. Now in a RCT, we do a process called randomization to account for all the known confounders. And with the process of randomization, we assume that all the unknown confounders are also matched. But in an observation trial, we cannot match the unknown confounder. So there's a confounding bias which can arise. Second is immortal time bias. So now what is immortal time? So if suppose we look at this patient A, B, C, D, E, T0 is where they are diagnosed. So once they're diagnosed, they will be part of the study. If you're looking at an intervention, as soon as when you know that they fulfill the criteria to get the intervention, they would be under follow-up. But they would have received the treatment later. This time from when they are included in the study and when they have got the treatment is called the immortal time. Now, this is a time where the outcome of interest cannot occur. So, if outcome is death, if the death occurs here, they would not get the treatment. So, here the outcome of interest cannot occur. This is called immortal time. The other term used is unexposed. So, in this time, they have not got the treatment, so they are unexposed to treatment. Here, they have got the treatment, so they are exposed. Now, what is immortal time bias? We'll look at an example. Suppose if you're looking at effect of SCQ in patients hospitalized with COVID-19 infection. So look at this first patient. So this patient is admitted. So he's part of the follow-up. So this would be time 0 when it begins. But he would have actually got the SCQ after some days. That is days, suppose day 2 he got. So this pre-treatment time is called immortal time. Look at this patient. This patient has not got SCQ. So he would be classified as non-SCQ treated. If somebody has got, they would be classified as exposed or SCQ treated. If you look at this patient, so the patient is admitted, time 0 has started where they are part of the study. The patient has died before he could have received the treatment. So if the patient would have received the treatment, would he have benefited? We do not know because outcome has happened here. Now, suppose this was a severe disease. So that's why they have died and not got the treatment. So we will overestimate the effect. So this bias is called immortal time bias. So immortal time bias is just misclassification when this pre-treatment time is incorrectly classified as SCQ exposed person time. So here patient has actually not received the death, but because you have started counting from here, patient has not received the medication because he died before that. So if you classify as non-SCQ treated, it's called a misclassification bias. So this causes immortal time bias. It causes overestimation of the effect in the SCQ treated group. So this is what we looked at immortal time bias. So immortal time bias, the follow-up happens before the treatment is initiated. If you look at this diagram, so this is the start of follow-up. The blue dots are the treatment when treatment is initiated. This is the treatment exposure. This is the death. Now suppose instead of starting follow-up here, so we know this leads to immortal time bias. If we start follow-up here, people get treatment and they are on treatment. And if you start follow-up here, what can happen? So this patient, this is unexposed, not got treatment. You started follow-up, has got treatment. You would classify as, so if you have started follow-up here, this point patient has not got treatment. So this would be untreated. Now, this is where you are starting the follow-up. Here, if you got treatment, you would call as treated. This would be untreated and this would be treated. This is not got treatment, would be untreatment. Here, the patient has died before you have actually started follow-up. So this could have been severe disease. That's why they have died before. This is called depletion of susceptible, prevalent user bias. And this has just happened because your start of follow-up is after the treatment initiation. So just the same set. So this is also called as selection bias. This is also called as misclassification bias. So selection bias happen when the eligibility occurs after assignment to a treatment strategy. Misclassification or immortal time bias occurs when the assignment occurs after eligibility. So just to summarize everything, time 0 is when you start the study. This square shaded part is the treatment assigned. And this black dot is when you start the follow-up. In an RCT, naturally they align. But in an ideal hypothetical RCT, all three things should align. The time 0, when you start with eligibility criteria is met, when the treatment is started and the follow-up started, should be all together. If suppose your eligibility is met before treatment is assigned, but you start outcome later, leads to selection bias. Similarly, if treatment is started and you start selection outcome follow-up, selection bias. Immortal time bias, if eligibility is met, treatment is assigned after you start follow-up. This is immortal time bias. Now, the other thing which can happen is eligibility is met, you have started treatment, but you have not started follow-up. So this is called the grace period. So you start follow-up only after the treatment is started. So if not, it will lead to immortal time bias. If you start follow-up later, this is called the grace period. So these are the biases we should look out for and plan to reduce. How can you overcome confounding? You should measure and calculate for all the possible known confounders and adjust for the confounders. Now, the other biases we can overcome by make sure you align the eligibility criteria, assignment of strategies, and start of follow-up at time 0. If all of them are assigned, you can actually avoid the selection and the misclassification bias. Then there are some modeling methods to do to make sure that you can emulate it into a randomized control trial design. So what is the process of doing a target trial emulation? So it starts with a question. So what is a question? Is it an intervention or exposure question? So you can look at intervention, treatment, vaccines, any of the question, similar to what we do in a RCT. You make a target protocol and you try to emulate the target trial. So this is how you would make the protocol. So you have the similar components which is there in the RCT. You make sure that is there in the protocol and you emulate each of that. And this is just a example of one of the target trial framework. So similarly, eligibility criteria, strategies, assignment, follow-up, outcome, causal contrast, intention to treat, assumptions, and the analysis plan. So you specify the target protocol, emulate, and do modeling to make sure there's proper emulation and then the results. Today, we will look at a case where intervention is in question. So suppose you've got two patients, both are similar, 45 to 50-year-old, has come with short 5 days history of fever, cough, and breathlessness with examination which is suggestive of a pneumonia. So patients, similar age group patients with pneumonia on oxygen with tachypnea. Patient A has diabetes. He's a PL-HIV on ART with history of splenectomy in past. Patient B has got uncontrolled diabetes with recent hospitalization for an infection, purulent cellulitis. Now, when they come with severe pneumonia, there are multiple broad spectrum antibiotics we can use. We can broadly classify it into multiple empirical antibiotics we can use. One could be a broad spectrum antibiotic, starting, hitting hard and coming down. One would be based on the etiological possibilities you consider. So based on the guidelines, so you would use a beta-lactam plus minus macrolide of fluoroquinolone. So which approach is better, giving broad spectrum or to give a possibility-based thing? So keeping a note, these are probably moderately immunocompromised hosts, HIV with splenectomy. Now to answer this question, we will look at this study published in IDSA, target trial emulation of empirical antibiotics on clinical outcomes in moderately immunocompromised patient hospitalized with pneumonia. Now today we will be looking at a reporting checklist. So they have used a target statement and we'll be looking at the checklist. Before we go to the checklist, we know that this is an emulated RCT and we are used to presenting RCT in the PICOT statement. For this study, the PICOT statement, the population were moderately immunocompromised adults with community-acquired pneumonia. Intervention was broad spectrum. Comparison was a standard community-acquired pneumonia regimens. Primary outcome was mortality in 30 days. They also looked at secondary outcome with length of stay, ICU transfer, readmission days, C. diff infection, and adverse effect. Time period was from the date of admission to 30 days post-discharge. Now, this is a checklist, a 21-item target checklist. We will be going through that and see how much the study they have published aligns with the checklist. Now, the first part of the checklist is about abstract. mainly to make sure they identify that they have done an emulator target trial, what are the sources and the key assumptions. So this is actually the abstract which they have written. It's given very concisely and very well. So they have told that this is actually a target trial emulation. They have told where they have taken the data from, and they have summarized the results, conclusions, and methods very well. Second part is the background. What is the causal question you're trying to answer, and what is the rationale? So they have started with the background, they've given the rationale, and they've looked at what is the question. They have explained what is the question they're actually looking at. So they're looking at which intervention is better. Methods. So in the methods, the first is where the sources of the data they have got and how they've got each of the data. So we know that this is actually large observational data which they're trying to emulate into RCT. So they have actually taken data from 69 hospitals in Michigan, and they have actually described in detail how they got the data from records, from review, from discharge data, lab data. Now, in the target checklist, they have given a template how to. Yes. Yeah, the question is, was the data collected retrospectively? Yes, this is a data which is available in a consortium in Michigan. They have got it retrospectively. So this is from the target checklist. So in the protocol, they have given a table which needs to be considered. So first, what is a target trial you want to do protocol and how you're going to emulate. So this is how they have given how to fill it. And this is you're expected to fill it. And if you have taken from other index trial, like from other observational trial, so you have to fill this table. Now coming to this study, to the checklist. So second part of the checklist is about the target trial specification. So the first part is, have they given a protocol? So this protocol they have actually given well in the supplementary reading. So they have actually correctly identified what is eligibility criteria, including inclusion and exclusion, what are the treatment strategies they are using, what is the assignment, and what is the follow-up period, outcome, what do they want to look at, and what is the analysis plan. Second part is component of the target trial. One is the eligibility criteria. So they have given an inclusion and an exclusion criteria in detail.
The supplementary table after procedure, this patient will be randomly assessed to either empiric and evaluate treatment strategy and will be aware of strategy to which they have been assigned. This is a randomization and it cannot be happening.
So here, so you can actually do randomization. In the modeling method, you can actually do randomization. But if you look at this protocol, so they say that ideally you have to say how you're going to do. You're going to randomize and how you're going to emulate the randomization. So their protocol stated that they're going to randomize, randomly assign. So this is an emulation model. So you would randomly assign. But what they finally did in the emulation is they have just assigned the normal, they had just assigned patients if they fill the eligibility criteria. They are not mentioned about randomization in the study. But in the this is from the supplementary. This is a protocol. So this is a protocol before the study was done. But in the final study which they have actually written up, they have not mentioned the word randomly assigned. They have done assignment. So once they fulfill the eligibility criteria, they have done an assignment. But the randomization, they have not mentioned in the final study which they have published.
Ideally, you want to randomize. That is a target. In target trial, you are going to mimic randomization. So the whole trick of target trial is how did they mimic randomization? That she'll explain the methodology. But you must say that in real life, I wanted to have randomized. Because I have observational data, now I have to mimic that. So that is the whole trick of this target trial.
So the protocol stated that they would be randomly assigned. But in the study they have done, so they have done assignment. There was no allocation concealment assist. So this one patient who is eligible was assigned by a modeling, which I'll come to that. I don't think it would have been possible to conceal allocation in that. Second, eligibility criteria, inclusion, exclusion was detailedly described. Third, what are the treatment strategies? So they had two arms. They had one arm with a standard therapy regimen. Second arm was a broad spectrum regimen. And they have described what do they mean by broad spectrum treatment and what do they mean by standard regimen. Assignment procedure. So this is, they had written randomization, but here they have written defined assignment. And they have done adjustment for non-random assignment, including some modeling method, which I'll come to. Next is what is a follow-up. So the follow-up begins at treatment initiation and within 2 days. So the 2 days was the grace period and starts at 30 days, either if they die before or at discharge or 30 days from the onset. They have done sensitivity analysis, which they have described. Second, outcome. So they had a primary outcome was mortality. They also looked at secondary outcome, which they have explained in detail. Third is what is the causal contrast. So this they had actually told intention to treat and they have done intention to treat. Identifying assumptions. So this actually has to be reported as one of the columns. So they had reported in text inside the, in the text. So they looked at confounding, covariate adjustment. They've done a sensitivity analysis and they have reported, and they have done it and they have reported. What is the analysis plan? So the statistical analysis and the sensitivity analysis, they have reported in detail. And what are the results? So coming to the results, so ideally the result has to be explained in text, given in a flow diagram, and you have to report the individuals with the baseline data. So the results they had given in text, they have also given in tabular column, which I'll come to. This is a flow chart which was given in the supplementary material. So these are the patients they had screened, patients who met the exclusion criteria, and this was the exclusion criteria. These were the patients who met the inclusion criteria. These were the patients who were assigned for study. And these are the patients who went to the standard arm. And these are the patients, 1,596 patients who went to the broad spectrum arm. So this is the consort figure. Normally it starts here when we see in a normal RCT. So this is similar flow diagram. So here some of the patients had crossed over, but they were analyzed in the same arm. And they have given how many people had actually crossed over and switching randomization after the after the first where they were assigned to. The modeling method they had used here for emulation was a propensity score model. What does that mean? So propensity score weighting and matching methods. So propensity score is a score a patient receives on the probability of whether they will get a certain treatment, and that is based on the baseline characteristics and the covariant. And the score method is a method to mimic randomization by balancing the baseline characteristics. You can do by different way. You can weight, stratify, or match. We'll look at this diagram. So suppose this is the entire population which was screened, and this is a sample which is taken. If you look at this sample, suppose this is the control arm, blue is a control arm and red is a treated arm. We look at, when you look at that, among the 10, around 7 are circle, 2 is hexagon, and 1 is 10. So they are not fully similar, correct? So it's 70, 20, 10%. This is the control arm. Now, suppose this is a study population in which circle is 50%, hexagon is 30, and 20% which are squares. There are multiple ways to do this randomization and modeling. So one of that is randomized allocation. One of the way to you can adjust propensity score is randomly allocate. So that is what we normally see. So you randomly allocate and they are fully matched. Now in cases, this is if when you do normal randomization, they are fully matched. Now in cases when you get a sample like this, when they are fully not matched, you can do propensity score modeling, in which you can do 1:1 matching. So you take one circle to each circle. So you can see that they're fully matched, but the numbers are less than the final numbers. But they're fully matched. Then you can analyze in here. Second one is you can do a inverse probability weighting to look at the effect in the overall population. So you know the overall population looks something like this, 50, 30, 20. So you can give score to that. So you know that the circles are only 3. So out of 10, you go score of 3. Circles are 7, 10 by 7. So you give weight based on the characteristics. And then you would get a population which is like that, looks similar, but the numbers are same. Other way to do a inverse probability of weighting is treatment is the effect in the treated. So we know this is a treated arm. So if your treated arm is same, if you do adjustment in the control, how will the results look? So this is the effect in the treated. So you do make adjustments in the control to match them to the treated arm. Your final will look something like this. So this is a method they have used here to do a randomization and to get two equal arms. So they have done inverse probability of treatment weighting. This is a propensity score model based method. So they are re-weighted according to the inverse of the propensity of actually receiving the treatment. So you get a pseudo population which looks very similar how we see in a RCT. So these are the baseline characteristics they have got. This is before the weighting. This is after that. If you look at here, that some of them are quite similar, age, gender. But if you come down, like hospitalization in the past 90 days are quite different, 18 and 38.7. But after matching, they look quite similar, 31 to 30. Received antibiotics in the past 90 days, which is a high risk for a resistant organism. You can see that it was different, but they have matched it. So here, what all known confounders can be matched. Unlike in RCT, where the unknown confounders we assume to be matched, here the unknown confounders cannot be matched. So you have to actually plan and look for whatever confounders can happen, and you can match it. So this is the second baseline. So they also thought if they took different severity of infection, they would be able to get a better coverage. So they looked at QSOFA, complications, severe sepsis, which were all different, but has become similar after the modeling. On immunosuppressive medications, that has also become similar. They had also taken patients with solid organ malignancy on chemotherapy for the last 30 days, which was different before but has become similar. So they had taken from 69 different hospitals. So they had also accounted for the hospital size and number of beds. And you can see that that was different initially, but they have become equal after matching. They had both academic hospital, profit and non-profit hospitals. Now, this is the other reports which they got. So what are how many of them are culture positive? How many of them are MRSA pseudomonas, which we are worried about when we cover for a broad coverage, blood sample collected and the PCR collected. So missing data, so you can actually impute missing data. So here they said the missing data is very rare and they are not imputed the missing data. This was the primary outcome results. So the primary outcome was mortality end of 30 days. If you look at mortality, it is not statistically very different. They've given also in a forest plot. So few things which favors the standard care is readmission, transfer to ICU, and the last duration of hospitalization. That seem to be better in the standard arm compared to the broad spectrum arm. There's no mortality benefit as such to give a broad spectrum coverage. Second, just the characteristics of among the patients who were hospitalized. So if you look at the duration of antibiotics, which was more in the broad spectrum arm, MRSA cover and Pseudomonas treatment was more, 94 versus 5 in the broad spectrum arm. So this was apart from the, in spite of the crossovers which was there. This is the time to mortality, which is not much different. And this, they had given a graph of the broad duration of the broad spectrum antibiotics. We can see that it's not a normal bell-shaped curve. It is skewed diagram. And looks like the most number of days of antibiotics received were 4 to 5 days in each arm. But the broad spectrum antibiotics, they had got for a longer duration, even extending up to 38 days. They had done a nested trial emulation sensitivity analysis, which showed the same result. And this is the last part, second last part of the checklist, which talks about discussion. So they had interpreted the results. They had also mentioned about their limitations. Other information, ethics. So they are not, normally they write, we have obtained approval from the ethics committee. Here they're not mentioned that, but they have actually given contact to the IRB review board. So they would have gone through ethics committee. The registration number was not mentioned anywhere, but other part about data sharing, funding and conflicts of interest had reported well. So in this checklist, I think apart from the registration, everything else it aligns quite well with the target checklist. Now coming to our patients, both the patients. So here, what would I do? So here, though they are moderate immunocompromised, I would actually give a standard therapy only and keep under follow-up. This patient, I would consider this recent hospitalization and infection as a risk for MRSA and cover for MRSA along with the standard therapy. Thank you.